Welcome everybody to today's webinar. I'm Charlotte, I'm the Patient Advocacy Manager here at Leukaemia Care, and I'll be moderating today's session. I'm really pleased to be joined by the panel that we've got in front of us. It's going to be a really exciting topic. We're going to talk a little bit about making the best of your CLL appointments, and obviously this has changed a lot, I guess, since March 2020. So hopefully we can talk a little bit about those changes and maybe what we expect in the future. Not that any of us got a crystal ball, but we'll see. I think we'll do introductions from the panel first, but then I have a short poll to run with the participants who are on Zoom. So just to sort of see who we've got joining us really and what your experiences have been with appointments before we go into our first speaker. Before we do that again, I just wanted to remind you on how to ask questions on our webinars. So if you are with us on Zoom, you can use the chat function, which is the speech bubble in the toolbar, which is usually at the bottom of your screen. Just click on that. You can send your questions either to just us panelists if you want to remain anonymous, or if you'd like to share it with the wider group, you can also choose to share it with panelists and everyone else. If you're on Facebook, do leave us a comment because we can still pick those up, and we have people who are forwarding those over for us so we can engage with everybody regardless of where you're watching us. Okay, so quick introductions and then we'll do the poll. So Nick, maybe you could just introduce yourself for me and talk a little bit about why you're on the panel with us today.
Thank you, Charlotte, and good afternoon everybody, and thanks for inviting me and allowing me to join you in capacity as a patient today. So first and foremost on the panel today, I am a CLL patient myself. I was diagnosed in 2009. I was on watch and wait for some considerable amount of time, I think 7 years. And following that, I was treated with fludarabine cyclophosphamide rituximab FCR, as many of us know. Didn't work too well for me for that in particular. And then I'm now on a second line therapy with rituximab. So I've had some experience over some time as a patient of the different types of appointment, different locations. I used to be treated in Wales. I'm now being treated in the Midlands, and I work quite closely as an advocate. I work for Leukaemia Care, and I've worked as an advocate for many times with all of you as the patient community. So I'm able to join the panel today to share some of your thoughts, but please do make sure you keep them coming in through the questions. We want your real questions as well. So from that point of view, I'm kind of able to sit on the panel in two capacities and act as a liaison. So I work for Leukaemia Care as patient advocacy and healthcare liaison officer, which actually, you know, I liaise between the patient group, the charity and the clinical community. And it's a pleasure to be with Dima and Helen on the panel, who I work quite closely with the UK CLL Forum and the UK CLL Pinnacle community.
Thank you, Nick. Helen, you want to introduce yourself for me?
Hi, it's a pleasure to join you today and thank you for inviting me. My name's Helen Knight and I work as a CLL specific nurse specialist over in Nottingham. That's a role that I've been doing now for 9 years now. So Nottingham, one of the first to have a CLL specific nurse specialist. And we're slowly gathering in numbers now as they've seen there is a need. So I've managed to see over the last 9 years how the landscape's completely changed for CLL and how the patient group has grown so much along with the treatment changes. So the role of the CNS, I think, has become much more recognised as a real need for patients with CLL now as a support.
Great, thank you. And Dima, please.
Hi, thank you very much for inviting me to speak today. I am Dr. Dima El-Sharkawi and I'm a haematology consultant at the Royal Marsden Hospital. So I work over 2 sites in Sutton and we've got a site in Fulham Road, and I treat patients with different types of lymphoma and of course also CLL.
Thank you very much. So before we go into your talk, I will just launch this poll that I've been discussing previously. So everybody should now have some questions on the screen. If you're on Facebook, I will just read them out in case you'd like to contribute to the discussion in the comments. It would be good to see what your experience is too. So essentially what we'd like to know is, what type of appointment was your last appointment for your CLL? Were you seen telephone, video, or did you attend in person? Did you Did your appointment type change much over the COVID period? Did you move from in-person to phone or phone to in-person, or did it depend a little bit? That would be really interesting for us to know, to contextualize the discussion today. Do you have a preferred appointment type, phone, video, in person, or does it really depend on anything, on you, on what you're there for? That would be interesting for us to know. What would you say your opinion of phone and video appointments is? And has it changed during COVID? Have you become more positive about phone, or are you having a bit more reservations about phone appointments, or do you feel much the same as you did pre the pandemic? And just a final question, which may look a little bit odd to stand out, but we're curious to know how many of you have access to a CNS like Helen, just to make sure we're inclusive of everybody listening today. I appreciate that not everybody has access to a CNS. So we've got about half the people having voted so far. So I think I will leave it 1 more minute. Some interesting responses so far. Nobody has had a video appointment as their last appointment. It's really interesting that video, it was touted as a thing for a while, but nobody's really had one yet in this group. That's really interesting. Most people have moved from in-person to phone or video, which is perhaps to be expected. And most people prefer in-person appointments generally. We can certainly discuss that as a panel. Okay, I think I'll end the polling there so we can have a quick look at the results overall. So 55% of people said their last appointment was a telephone appointment, not unexpected. And as I said, most people have moved from in-person to phone or video over the course of the pandemic. Preferred appointment type is in-person for 73% of you, with the next group of you saying it depends on the type of appointment, which is really interesting. We will discuss that a little bit later. This is an interesting response. Most people feel the same about phone appointments as they did before pandemic, but it's actually quite varied across all the options. Some people have become more negative, some people have become more positive about phone appointments. Again, we can discuss that. And thankfully, 64% of you have access to a CNS, but we will take into account the 25% of you who've said you don't, and we will discuss what to do if you don't have a CNS, who you should be in touch with, hopefully. Thank you for that, guys. I think that's really interesting context for us to set the scene a little bit. Right, without further ado, maybe Dima, you could give us your thoughts on today's topic to set the scene a little more before we have a bit of a discussion between us.
So hopefully you'll be able to see my screen, and let me just put it on presentation mode there. So I've just got very few slides, just as Charlotte has said, to set the scene for today's webinar about getting the most out of your clinic appointment. And it was actually very interesting to sit back and think about this from my perspective. So I kind of took it back to basics about what is the role of the outpatient clinic, and for me it's really about relaying information, and this has changed over time. So I guess before, in generations gone by, that the information was very much the patient telling the doctor what was wrong with them, the doctor making the decision and telling the patient, okay, this is what we're going to do, if at all telling them, or just doing it. And over time, I think it's become more of a two-way thing, and particularly with a condition like CLL, which is in many ways a chronic condition that you're going to get to know the medical team and the healthcare professionals over a long period of time. It has become much more two-way, but of course that is a bit dependent on the doctor you've got, and different doctors are going to have different ways of doing things, and the way that I talk to my patients is going to be different to other consultants around the country, and similarly patients are going to be different. I think you're going to presumably be quite a self-selecting population of patients or family members of patients with CLL, because you're attending this webinar, so the amount of information you may want to get from your healthcare professional be different to someone else who may not really be interested at all, and so that varies. And of course, during your journey of since diagnosis, to wherever you are in the pathway of your disease, how much information you want to give your doctor and how much you want to receive from your doctor is going to vary during that time within that individual. So I think there are lots of different factors, which means that this is a very malleable relationship. Essentially, it's about relaying information to and from one another. And I guess just putting it into a bit more detail and context, the information that we're primarily trying to get from you as healthcare professionals is the clinical information that's going to help us make the decisions as to, do you need treatment at this point? If so, what treatment am I most likely to want to give you? So symptoms, obviously we'd want to know about the symptoms of your CLL. If you're face-to-face, you may have been examined to see how large or not large your lymph nodes are. Any side effects of treatments that you may be on, because of course, as been alluded to already, that the landscape for treatment for CLL has changed considerably over the last few years. And so a lot of you are going to be on continuous therapies, which in themselves have side effects, which we may need to be dealing with. And then there may be other medical concerns that are either related to the CLL. So we know that you're going to be more increased risk of infections, for example, or unrelated to the CLL, but if it involves needing new medication, may have an impact on what we do. And then, of course, in terms of the information that we give to you, a lot of patients want to get the clinical information back. So a lot of you, and I'm sure a lot of you on this call, are going to be, for want of a better phrase, professional patients. And as well as giving us clinical information, you're going to want to know what your blood count is. A lot of you are monitoring your own white count, hemoglobin, platelets to assess how close you are to needing therapy or how you're responding to therapy. And of course, one of the major things that we need to do is, apart from relaying the information on the latest trial data for the different treatments, it's putting it into context for you as the individual. It's all good and well us telling you, well, so many percentage of people responded to this option and for this length of time. But what does it mean for you as the individual? Are there any unique things about you that might make you more or less likely to respond? So it's putting that into context. And of course, some of this information you may get from elsewhere, not just from your doctor or healthcare professional in the clinic. So some of you may read the actual papers from the trial. Some of you may get it from healthcare forums or support associations as well. So that's kind of what I thought, as a nutshell, what the real role of the outpatient clinic is, or the clinic consultation. And of course, then there is going to be variability as to when you have your appointments, how frequent they are, and obviously how much information you're going to get at each consult is going to be different as to where you are in your journey with CLL, how often you're being seen. I think where we do the consultation will have an impact on the consult itself, and you've already highlighted some of the differences between virtual and being in person. And then obviously there's that impact of who are you going to be with. So from the medical side and the healthcare professional side, are you just having a consult with the doctor, or is the CNS involved if you need dietitian support or psychological support? So that's not just about seeing a doctor. There's the other people that may be involved from the healthcare professional side, and then of course from the patient side, who else is involved or participating in the consult can have an impact on how it goes. Do you have family members with you, which I realise is very different now to how it was pre-pandemic, but that can have an impact on the consult. And so I thought that it is useful, and Nick had mentioned this already, kind of what you want to get from the consult and what we want to get as healthcare professionals from the consult does depend on where you are in the CLL journey. And so, you know, when you're first diagnosed, then you may be more interested in understanding the disease, the natural history of the disease, so how it tends to develop, what the expectation is, prognostic markers, and the amount of information you want at the beginning does vary quite a lot from one patient to another. And then Then there's the period when people are being actively surveyed or undergoing watch and wait. And then it's, from our point of view, really trying to work out when are patients approaching needing therapy. Then obviously when patients are on therapy, are there complications with the therapy, how they're responding to the therapy as well. I have missed out a big part at the bottom. I've skipped straight to the response to treatment. Is before you start the therapy, it's what to treat with. And we're going to talk, I think, later on about shared decision making. Now that we have the luxury of options for patients with CLL, shared decision making, so that's us telling you what options are available and why we might prefer one option to another, is important, but also giving you the opportunity to say what might be important to you. And certainly the NHS have a 5-year or long-term plan, and shared decision making between the doctor and patient is a key part of that plan. So this is quite an important thing. And then alongside this, and I've put it outside this kind of cycle because it is something that we should be thinking about all the time, is about some of those complications or things that we know are more likely to occur in patients with CLL, which perhaps we didn't talk about so much, or some clinicians didn't before COVID, but now a lot of our consults are dominated by COVID, and almost for CLL takes a backseat for many people. And so it is about talking about that risk of infection. How can we reduce that risk of infection with vaccinations? If people are getting infections, how can we manage them? We do know that patients with CLL have a slight increased risk over the general population of other cancers. So some of what we do is looking for those other cancers potentially, so that we can try and diagnose them early. And as I've already mentioned before, other perhaps unrelated diseases, but that may have an impact on how we manage the CLL. For example, if you're on therapy for heart conditions, it may have an impact on what treatment we would want to give you for your CLL, for example. So I think that was the only few things that I wanted to say, just to set the scene really, before I hand over to Helen to talk a bit more, and then for us to have more of a discussion about some of these aspects.
Thank you, Dima. That was really, really helpful. And I particularly liked your first slide where you really went back to basics and thought about what the aim of the conversation was. I think sometimes we don't really go back that far, and I think that's really important to start from the very basics. Really interesting. Thank you. Helen, yes, is there anything you'd like to add to what Dima's already shared in terms of setting the scene here? What's important on this topic for you?
I think it's good to hear the 64% have a CNS. It'd be nice for it to be 100% really, that everyone has access to a CNS really. And that's our aim really, that you've got that extra support, that I think sometimes the conversations with a nurse can be different to the consultant. Sometimes they like to do both. Some patients do and would ask very different questions to a CNS maybe. And I think it's reiterating that there's no right or wrong what to ask and say in your consultations either, and everybody's different and your questions will be different over time throughout your journey really. And I think hopefully as a CNS we're there to support you through that as your questions change, or sometimes you might want to ask something again that you've already asked before, but we can reiterate it or say it in a different way to make sure that people feel empowered really. We want to empower you with information at the right time, at the right level for when you want it, and to meet expectations. I think my role really is to help us meet your expectations at all times, or even surpass them if we possibly can really, just to make sure that you feel happy with the information you given, and that we can build on that through time and to build that relationship really. We were saying about hopefully the CNS is your constant person there. You may see different people throughout the time, but we'd hope that we're there all the time. We can build that relationship with our patients, and be able to pick up. I think sometimes with telephone you don't get those non-verbal information. Sometimes it can be quite difficult that you sort of see somebody and think actually they're not right because you've known them for quite some time, whereas on the phone you might not pick that up sometimes. So there's lots of different things, I think, that although there's a place for telephone conversations, I think, now at the moment, but I do agree that, yes, most patients agree a face-to-face sometimes is good, just to check in and see people face-to-face.
Thanks, Helen. That's really, really helpful. So I just wanted to, before we go into the questions, I saw quite a few people joining us as we were going through that introduction. So just a reminder, if you do want to ask questions, please use the chat function, or if you just joined on the Facebook, in the comment section on Facebook. And I have seen a couple of questions already. And if I don't answer them immediately, please don't be offended. That doesn't mean I've not seen them. I'm just going to slot them in at the relevant point, and I hope that's okay. And if I forget you, please do flag it in the chat box again that you're still there and you still want your question answered, and I'm more than happy to go back to it. Someone's just raised their hand. I think we've got so many people today that would be very difficult for me to manage. So if possible, if you could use the chat function to ask a question, that would be really, really helpful. Right, into the questions then. A few ones that came to mind from some of your slides, Dima. So you mentioned frequency of appointments, and I wondered whether you could clarify whether there are guidelines around, you know, the frequency of appointments and how that changes over time or based on where you are in the journey. And is there something that people should expect as sort of a minimum standard, if you like?
The short answer is no. There's very little guidelines on that, and there is no expectation. And I think it's very variable as to where you are. Probably what we do is very different to other clinical areas. I think who you see makes a difference. And I'm going to say a lot of things that are kind of off the record, but one of them is sometimes if you see someone junior, they're going to be quite nervous about leaving you a long period of time before you come back. And so it's easier for them to bring patients back perhaps sooner than they need, than someone who's more experienced, who's more comfortable with letting them go. So, I mean, there's so many variables in it that I think everyone's very different. And, you know, it's different for different patients, even at the same point in the journey. Some patients need more support, more information, and it does need more appointments. But I would say personally that if patients have been stable for a very long period of time, then I'm quite comfortable leaving it months before they come in. But we have quite a good, I hope we do, open access system so that if people do have problems and that we have empowered our patients to know when to call us, then we are happy to see them sooner. And I think that's the key thing, that if you feel that you can contact your clinic or your hospital if there's a problem, and I think most patients then are comfortable with not having too frequent an appointment.
Yeah, so I guess the response to patients is to, if you're not sure why certain things are done in a certain time frame, then just ask the question. I'm sure someone will be happy to help. Yeah. Helen, is there anything you wanted to add on that point?
No, I think it's true. It varies, doesn't it? When we go to national meetings and things, with nurses, the frequency of appointments just really does vary. Or even people doing discharge, if they're stage A, watch and wait, then they get discharged back to the GP. Other areas don't do that. So it is really, really variable. But I think I reiterate, yeah, to have that confidence to ask if there's a problem, or if you feel things have changed and you've still got a month or so before your next appointment, then just know who to ring and when.
It's interesting that the discharge to the GP is quite a variable thing. I've seen quite a few people struggling with that, as in terms of coming to us on a case-by-case basis and saying, I'm struggling to get the information I need because the GP isn't as in touch with CLL specific stuff, which is obviously not their job. Dima, is that something you do in your area? Have you had much experience with discharging people?
Again, I guess where I work is quite unique in that we don't have so many patients that are watch and wait and frontline and early stage. Just we don't have many direct referrals from GPs. So most of our patients are at the more severe end or already requiring therapy. So it is different. And, you know, if you have a big catchment area, or your hospital where you're close to has a huge catchment area and they have to cut down the clinics, then from a clinical perspective, the chances that those patients are going to need therapy in the next few years is very low. So you can understand from a service level that it's just not feasible to keep all these patients in the clinic. But I can also understand from the patient side of things that actually, yes, the GP can monitor the blood count and refer back when you hit a certain trigger. But like I went back to with the basics, the clinic appointment isn't just about you giving us the clinical information. It's some part of it is us giving you the information. And I think that's where that relationship falls down, not through the GP's fault, because obviously they're GPs and that's not their specialist interest.
Yeah, I think there's a lot more exploration to do on that front.
Yes.
I was going to bring you in just a second, Nick. There's one more question sort of round this section off. Someone's asked who decides who the outpatient appointment is with, and that's probably best place to either Helen or Dima. Helen, do you have any thoughts on that? How is it decided who someone sees?
I think ours will always see a consultant or a registrar to begin with, and then once they're happy with seeing how blood tests are going, then ours refer on to a nurse-led clinic after that, if they feel that they're for monitoring. If they're on treatment or about to start treatment, then would definitely be one of the doctors that would see them.
How about you, Dima? Is it fairly similar for you?
Fairly similar. I think this is going to be a lot of repetition, that it is going to be very variable across the country. And I know that continuity is important and there are advantages, but equally, I mean, working in an NHS hospital, everyone has to train. So part of the training to make the next generation of consultants is that registrars see patients, and registrar training means that they do move around, so they're not always going to be in the clinic. So usually with us, literally it's just a pile of papers of people who are in clinic and we just take them from the top. So sometimes it'll be me, sometimes it'll be the other doctors. So if for us personally, if patients are approaching requiring therapy, so perhaps in that relationship, actually the main emphasis is relaying information to the patient, and myself and my other consultant colleagues, we will see the patients. We will certainly make a point of seeing patients when they're newly diagnosed and when they're approaching requiring therapy, because actually that emphasis on the relationship is us giving information to the patient. So we feel that we're in a better position to do that than perhaps some of the more junior registrars.
Great, thank you. Nick, your thoughts on what we've discussed so far? So frequency of your appointments and things, and this variability that's described, how is that for you as a patient and as a patient community, as you like? Because I know you represent lots of patients.
I think what I probably wanted to share on is it's very hard for patients when not understanding the reason for the time gap in between appointments and how that actually correlates to how stable your condition is. Somebody during the diagnostic process has to make that decision during your early CLL, and that takes time. And it takes a while for a patient. There's two sides to this. There's one side is that the further out your appointments are, am I right, Dima and Helen, that theoretically the more stable your condition would be, because you would be pushing for appointments sooner than that. And I don't know how you define and how you managed it. And I was going to throw that back to you about how do appointments change around if somebody's stable, if they're stable progressive, or if they're progressive and unstable, if you have a different structure and how you do that. But the other thing from the patient's point of view that's very hard to come to terms with is that feeling of being forgotten. And it doesn't just, watch and wait, as we call it, active monitoring, isn't just pre-treatment. It can be post-treatment, and it can be during treatment if you're on a continuous therapy. And the more time served you are as a patient, I think one thing we have to remember is, as chronic leukemia patients, we've got this for a long time, and we're going to learn a lot with time. But at the very beginning, and that also correlates probably to the shared decision-making element we talk about later, is the information giving in terms of, understanding somebody's level, the level of their understanding. Health literacy is a term that's taught, understanding their own condition, of why certain actions are taken. So it can be quite distressing if your appointments are very far apart and you haven't properly understood why they're so far apart. And once you understand that and you realize that you're very flatline, if you wanted to look at that, very stable, very early non-progressing CLL, or progressing but at a very slow rate, you can then be moved to primary care, for example, because it's more convenient for you and it's more convenient for practice, that somebody's just keeping the tabs on you and you can get on with normal life. And that's part of the problem that we have as patients, is how do we balance the bit being medicalized? We were never medicalized before. Suddenly we got diagnosed with leukemia. All of a sudden, everything hit the fan and we stopped living. And it's trying to find that balance. So it's, how can we get appointments? How can we get the information we need within a time frame when we're not being seen in the very beginning, if we've got very stable condition, once every 6 months? And it's trying to balance that part. So I think we're going to come on to that, aren't we? In terms of getting the best out of your appointments and living life as well, and how do you cope with the two? But I just wanted to emphasize that there. If you could allude a little bit more on that with regards to how you define the time between appointments. I think that would be helpful for me. I've noticed there are people here, for example, in the audience who've been diagnosed during COVID. They haven't had time to adjust to the diagnosis, and it does take time. And people might not be clued up or aware of how the interval between appointments is defined.
Yeah. Dima, did you have anything to comment?
So in terms of the interval, for us, or for me personally, I find if I had just one blood test as a snapshot, it's hard to see a trajectory as to how quickly or not quickly things are changing. And so I need to see a couple of blood tests, maybe 2 or 3 months apart. And also then if it's a patient that's newly diagnosed, it gives them a chance to come back once they've had a chance to process things from the initial consultation, to then ask further questions to really understand. And then it gives me a chance to see 2 blood tests at a different time points to get an idea of the trajectory of things. And then I space it out. And I guess the other thing to say with that is that, sometimes, and I've noticed some of the questions on the chat about examinations, and they're worried that the GP may not examine them as thoroughly, or that if the gap is too big in between appointments, that we might miss things very quickly. But actually, in terms of making that decision on when to treat, it's not if your lymph node moves from 1 centimeter to 1.5 centimeters, or your white count goes from 10 to 50 or to 100. It's primarily on how you're feeling. So if you're feeling well, it almost doesn't matter what size your lymph nodes are, because it wouldn't necessarily have an impact on when we treat people. So I think although I think as patients, it's quite difficult to feel like you're going to be the one that dictates when you start the treatment. And it's not quite like that, but in many ways it is. It's about how you're feeling. So this is why, as Helen said and I said earlier, it's fine to have appointments quite far apart, but widely spaced apart, but you need to have a clear pathway back in if you're feeling unwell.
Yeah, I think someone's emphasised that by saying they didn't feel comfortable with a GP, so they've gone back to the consultant. And it's having that ability to take things where you need them to be. And someone said they see a pharmacist, which is always nice to see, because I think pharmacists are becoming more and more recognised these days. Helen, I wanted to give you the opportunity. Did you want to come back on anything Nick said at all?
No, I think it's true. Yeah, I think we try and make an agreement with the patient when they come back sometimes as well, that they're happy with it as well, that it's a shared decision nearly. Sometimes when we do make it further apart, it is a big step sometimes, I think, and people really struggle to get their head around that. So if you're in agreement and you can come to some sort of middle ground, I think, really, to say that don't worry, you're never forgotten as well, that you have got that power of coming back into the service whenever you want. Going to GPs, I think we struggle because sometimes the patients get so used to us giving the information straight away. They have their blood test, we give them the result there and then. There's no gap, whereas maybe with the GP, they have a blood test, they wait a week, they've still not heard anything. They may then ring us to say, can you have a look and see if they're there yet? Because they don't get the feedback like they would really, I think, within a clinical setting. I think we struggle to get people back to the GP because they don't feel as safe sometimes. So it can be a struggle of not getting that information as and when they need it, and then it's adding to that stress and the period of time they're having to wait.
I think part of this comes with challenges with the NHS generally, which is a conversation for perhaps another day. Yes, it is.
It's an interesting one, because I'm getting copied in on every intercommunication of every consultation by telephone, which I never had before because I'm at home. But obviously many of us have never had, we haven't had a physical exam for close to a couple of years. I guess that could also relate to how time served you are and how comfortable you are with yourself as a person. You know, the second I felt a node reappear, which it hasn't, and I hope it doesn't, would raise alarm bells. And if I had health issues, then I would be talking about it. But things have changed a bit in COVID at the moment. And I think everybody's going to be feeling a little bit different, and their healthcare is delivered a little bit differently. But yeah. Because it really is hard trying to get information out of GP. You know, you've got to get past the pit bulls, for want of a better word. You're phoning up, you want your blood results, you've just given them your blood, yeah, and then they send it off to phlebotomy to the hospitals, and they share that then with your consultant, but you phone up to get it. You can't get it unless you get an appointment with the GP to share that information with you. So you have to then go back through the back door to actually talk to Helen by email. You know, any chance you could just share with me what the results are? And if you're stable as a patient, you don't really want to know, because you don't really care unless you have to know. I mean, I was going to share that other thing with the time served, the further apart your appointments are, you know, something's not likely to go bump in the night with CLL. Yeah, you've got time. If things creep up on you, what you've got to try not to do as a patient is not this, you know, think it's a new normal, because it shouldn't be a new normal. If symptoms, or if you're noting repeated changes building over time, then share them. Yeah, but something's not going to normally happen really quickly, is it? Unless you're really close, you know, unless you push things so far that you've got yourself really close to treatment where you become really vulnerable. But practice has changed in medicine. We're looked after a bit differently now. So I think that's the thing to emphasize to people on the call as well. Something's not going to happen suddenly, you know, not in most cases.
Yeah. Oh, am I on? Oh, I'm not on mute. Good. Sorry, it was bound to happen to me at some point. Nick, I wondered this question of CLL specialists. Before I ask the opinion of our CLL specialists, there's someone here is talking about how they see people talking about the importance of seeing someone with a specialist knowledge of CLL, and someone saying they haven't got that. What are your thoughts on this? Have you always seen a CLL specialist? Do you have any opinions?
I shouldn't smile about it and laugh about it. There's a lot of history on this. You know, I was with the CLL forum before, CLL support before, and we used to have a list of specialist CLL consultants on our database, and it was really hard to keep that up to base. And then we had to replace that with the language of that all haematologists should have a good working knowledge of CLL if they're in that area. I think without a doubt, the data does show that if you have a specialist involved in your care. Now, they might not, and this is my understanding, and you guys can correct me, they might not be directly involved in your care, but they might be part of your broader MDT. Yeah. Then if you've got a specialist involved in your care, data has shown, but that's old data, that it improved your outcomes. And I think that was during the days of chemotherapy. And that was something to do with when decisions were made about when to treat, that non-specialists used to treat people early rather than later with the chemo, and that impacted on outcomes. I think really at the end of the day, it's your relationship with your doctor that matters. If you're under a haematologist who within their specialisms is CLL, if they don't know the knowledge, if they don't know how to answer your questions, they will certainly be consulting with somebody that does. And I think the most important thing I've learned through time was, and I've got to admit, I found it really hard to comment on this on a personal basis, because I had one of those lucky postcode lottery things. I was diagnosed in a little mining town called Caerphilly in Wales, And the miners in that town had an arrangement with the University Hospital in Wales where haematology was delivered by the University Hospital of Wales Haematology. And this amazing fella at University Hospital of Wales, Professor Chris Fagan, became my doctor. And my first referral landed me straight on one. So I can't really comment from never having a specialist because, but from that point of view, what I did learn over time was it's the importance of the relationship that you have with your medical team. If you feel confident that they are as informed as they need to be, then you can work with them. If you feel they're not, well, that's a different matter altogether. And I'd probably hand that one back to the clinicians about how do you get a referral and what's the best way if you're dissatisfied, and what are your opinions if somebody wanted to get an opinion of somebody that's a specialist or another specialist, I've got to say, because obviously you're both specialists. And then there's the advocacy point of view from your point. So I'm throwing that back to you as well, Charlotte. From that point of view, how can advocacy help in that area?
Yeah, Dima, you first, please.
Without wanting to veer onto dodgy territory, I think your relationship with your doctor is a bit like a long-term relationship, and you are not going to get on with everyone. Everyone's going to be a potential long-term partner for you, and some of that may be information, and if you're not happy with the information or the system in that centre, then you should feel empowered to either, if not comfortable going to that doctor or that clinic directly, to say to be referred on, but going back to your GP to be asked to be referred elsewhere. It may be an information thing, it may be a personality thing as well. So the way that I talk with my patients may not suit everyone. And I think we've all been in it long enough to be thick-skinned enough to know that if patients aren't happy with your service, that you're going to get some patients that are going to want to go elsewhere, and similarly others from elsewhere want to come to you. And it is just one of those things that you're not going to get on with everyone, and they're not going to get on with you or appreciate your way of doing things. So whether it's an information, a personality thing, you have to feel comfortable with the clinic and the service that's being provided with you, and if to you, and if not, then and you're not feeling comfortable to tell them directly, then go back to your GP and ask them to refer you elsewhere. What I would say about the CLL specialist as opposed to a general haematologist with a condition that is relatively common, such as CLL, in relationship to other blood cancers, that I think most haematologists will, who do see any hematology cancer patients, will have CLL patients on their books, so to speak. And as Nick said, we have weekly MDTs with our district generals around here, so that whilst there'll be patients that some of our neighbouring hospitals that I've never met, I would still have an indirect influence on their treatment and be able to relay the information, or for example the latest trial data, to the to their primary consultant, so that I am indirectly involved in the decision making for the treatment. So yeah, I know lots of patients who are very happy with their service that's being given in District General Hospital, but it is a personal thing. If you're not happy for whatever reason, I can tell you, I'm going to put my hands on the table and say that some of our patients aren't happy with our long waits at my clinic, which I know is a routine problem in lots of NHS hospitals. But, if you're not happy for whatever the reason is, then you are entitled to ask to be seen somewhere else.
Going beyond sort of not happy with the service, someone's pointed out that CLL is a rapidly changing landscape at the moment. There's been a lot of new treatments, I think, in the last 5 years. Is that a contributing factor in terms of your ability as someone specialising in CLL and lymphoma to keep up versus someone who's trying to cover multiple diseases?
I apologise, Charlotte. I should have added there from a patient point of view. I think key touch points when decisions need to be made, I think there's great value then at that point, just making sure that you've got oversight with somebody that's got the depth of knowledge to make those. So I think that's at a point where I would, as a patient, suggest that having somebody on your team that is clinical, that is a consultant with a special interest in CLL, it would be of benefit. And if I can then be rhetorical. If I didn't have a specialist, because I obviously did have, I would have made sure that I had at that point, and I would recommend that to anybody. And I gather, and I was going to pass it back to the consultants, you know, I gathered that that's not a bad, you know, the consultants are open to that, because that's, you know, a key point in decision making. And that you don't often have to make many decisions in CLL. It seems to be periods of total and utter boredom, and then moments of total panic and having to make decisions. And making those decisions can be quite hard. Anyway, so I'll throw it back to you. Yeah.
Well,
So
I'd like to think it wasn't so panicked.
But it is in relative terms, you know, from a snail to a hedgehog.
Okay, but yeah, I mean, going back to what I said, the patients are all discussed in network MDT. So district generals do have their pathways to talk to the specialist, to understand and to have access, not just to the latest data as to choice of therapy, but also if there's clinical trials available to patients at various points in their treatment pathway. So, but, you know, if actually what you're getting from the consultant or the healthcare professional that you're seeing isn't enough information to help you make that decision, then ask to be referred to that centre to discuss it further. For some patients, that they're happy where they are, and that's enough. But if you need more information for you to help you make the right decision for yourself, then ask to be referred.
Great. I think what I'd say just on the referral thing, from an advocacy perspective, is we actually did a webinar a couple of weeks ago on advocacy and what we can do for you, and we covered how to make a complaint, how to get a second opinion in a lot of detail. So instead of going over that today, please do check our YouTube channel out. We covered that, and it was a really interesting discussion. Helen, I wanted to, before we move on, because I'm conscious we're taking a lot of time, we haven't actually talked about an appointment yet, but from a nurse perspective, obviously you said you were the first CLL specific nurse, or one of the first. How useful is it from your perspective to have that CLL specific knowledge to be able to do your job?
I think now, particularly because the treatments have changed so much, yes, it does make a big difference. And I take my hat off to nurses that work in district generals that are covering the whole of haematology, because it's just mind-boggling, I think, everything you need to try and cover. I find now, especially with the newer treatments that have come on, they logistically need a lot more planning. So as a CNS, I take that role on to be able to help patients, guide them through that, really. And we're even looking for a second CLL nurse. So that's how much it's changed in the last 9 years. We're looking for 2 people to do that job rather than just the one now. So I think patients feel safe that they've got a nurse that's just for them as well, that they can call on when they need to, and they know what's going on in the CLL world, really, and to see them visibly nationally as well, I think it gives them some reassurance and guidance, really. So I think it helps a great deal, really. I think if you can get a grasp, a good sound knowledge of what's happening, and to be there, or you can specifically spend time with them all the way through their journey, really. They're going to know you from start to end, really, and you're always going to be there. So that's that constant relationship that you can have with them.
I just mentioned something to add to what Helen was saying, that I think the role of CNSs has probably changed during that time, and Helen's kind of highlighted some of those changes, that rather than, you know, not just, but primarily having a supportive role, that they are a key members of the team, in particularly in the specialist hospitals or the specialist clinics, where they will be seeing patients themselves, and I guess taking some of the roles that doctors would have done in the past, which does, I think, help with continuity. You know, I'm sure all of you are aware that there's lots of junior doctor shortages, and we constantly have problems with lack of registrars. So having other people that are constant there, who are building that knowledge in CLL, such as Helen, it is really helpful. And the pharmacist that one of the people said that they'd seen recently is really helpful and supportive of the team. But I think it does mean that you have quite a lot of things to do, not just kind of doing the doctors or the traditional doctor side of things, but still maintaining that supportive role as well.
Yeah, absolutely. Nick, anything you want to say on the continuity of care point? Because you brought it up when we were discussing beforehand. And is there anything you wanted to add on the importance of that for you?
I think it is. I don't know how things have changed from that point of view, as I said, I think I mentioned, when I was diagnosed, for continuity of care, my key contact was my consultant, because there weren't at that time nurse-led initiatives, but things have changed now. I know when I was first being seen in Cardiff, there weren't very many navy blue uniforms. Now when I go into the day centre, there's a flood of navy blue uniforms. So I think things have changed there, but continuity of care is really important, because it is really difficult for patients. It's difficult for patients having to re-explain, or just feel that maybe the person they're with isn't as familiar or understand them. So I think from shared decision making, to be able to open up and learn together with somebody, continuity of care is important. So if you can find somebody to talk to on a regular basis, that's always going to be a benefit. And it was reassuring to see that it was 60% plus have got CNS. I was going to throw that one back, actually, that nobody else, when we were talking earlier about the gaps in treatment, in consultations, and that they tend to be wider apart when somebody's in active monitoring pre-treatment, if they're very stable. And you were talking about the route back from primary care. What's the route back if somebody wants to talk to somebody within the care team in between those great long appointments, if they are under yourselves, or even if they're under, is there a barrier if they're under primary care? Or for example, if you've got somebody that's on 6 monthly or annual monitoring appointments, how easy it's for them to be able to talk to your care team? That was something I picked up on the earlier discussion. Sorry if I've thrown this back again.
I think this is a bit of a centre specific question, and I guess
Right.
whether they formally discharged you from their care, and then it would be asking the GP to refer you back in, or if they've just kept you as a patient on the books, then you may be able to contact the secretary directly.
I've just been told off by Pam, so I apologise about that. I'm just going to add one thing on there. Is there the importance of patient groups, peer support groups, and information providers to help connect you. Sorry, I've just been told off by Pam, and I will shut up now.
That's fine. I think people see from the comments, I think who people see has been a really important point to start with. It seems a lot of variety and a lot of things for me to take away from that in terms of investigating further advocacy wise. Right, let's get to it then, shall we? So we're in an appointment, and Dima very kindly sort of talked about what the sort of things that we're trying to achieve in an appointment are. There's been a couple of questions on this. I'm just flicking back through the chat that I want to make sure we do cover. Graham asked, is there a list of questions that should always be asked at clinical appointments? I'm going to throw this to Nick first. From your perspective, do you always ask the same things?
Well, it's a difficult one. I'm sure I asked lots of questions in the very beginning, or I had questions to ask, but I always walked out with them in my hand in the very, very early days. And the questions I would ask now would be very different to the questions I asked then. I think that the first thing I had to work out was what questions were important and how practical for them, and how much are they going to impact on you, and determining what are your priorities, what's really relevant, what's going to influence you. And I guess what I've always tried to do is, if I've got an appointment, now before COVID, it was easy because you had an appointment, you knew you had to go and travel. I would actually sit down for a couple of hours before I was traveling the day before and have a sit back and reflect and gather my thoughts and write those down. And then they're never normally the same questions. There would always be the ones, are things progressing? How do things look, doc? How am I doing? Yeah, and that's really easy to get out of the way. So the perfunctory bit is really easy to get out of the way. And then it would be, at diagnosis, I wanted to know about how the disease would impact on my life, what was the important information I needed to know. I guess the information changed all the time. As you're going into treatment, you're looking at pros and cons. So you'll tend to be making decisions that balance your choices against what's practical for you with your life. So, the decisions, I think the most important thing is trying to take that little bit of time to reflect on the period that and where you are and what's your priority, and just define those. And if you can get them on paper, it's hard in COVID. because we get on with life, and if you've got a busy lifestyle, and it must be hard for the HCPs, for the doctors as well, because they're suddenly phoning you and you're not prepared for that appointment and you haven't got your questions. I don't know if I'm very helpful on that, but questions normally would be first early on, try to ask questions to help you understand your particular type of disease and how that might impact on your life. Yeah. Once you're then living with that, it tends to be understanding how that is in with you and how much that is affecting your life, and you'll learn that with time. If things are stable, you don't need to ask too much about the future. You can just learn enough information and maybe get on with things. If things are changing, then you're going to be looking to ask questions about what ifs, what, when. Yeah. But I didn't react very well to diagnosis in the beginning, and I spent loads of time asking loads and loads of questions and wasting lots of time with my doctors because I was asking questions that I didn't know. I didn't really know what the questions are. So I think it's a double act. I think it's working with the doctor as well, and the charities to actually arm yourself with the information so that you know what questions you should be able to ask, or you should be asking.
Yeah. I think you have been helpful, Nick. I think don't put yourself down. I think
it's a really difficult one because
it's a difficult question. Yeah,
it's a moving target. Yeah?
Absolutely. Yeah.
But I think preparing yourself from one point, just taking that time to take stock before you, and it was easy to do with an in-person appointment. It's not so easy with a telephone appointment.
Absolutely. Yeah. And that might be driving some of the things that people were saying about wanting in-person appointments if they're finding it hard to express those things over the phone. Dima, what's your response?
There's two aspects to it. There's kind of what you should be getting out of it and what we should be getting out of it. So I agree with Nick, preparation on both sides is key. So if you're feeling unwell, you need to make sure that you've told your healthcare professional that. So if that's jotting it down so that you don't forget, because part of what we will do is say, well, and I know that there've been some questions on that subject, is part of our job is to try and decipher whether your being unwell is related to the CLL or unrelated. Is this a sign that your disease is progressing, or is it actually something unrelated? Is it an infection? And just on that one point, it's not your job to or role to decide and try and decipher, and sometimes it's difficult for us to know which one it is. So if you're worried about anything, just ring the CNS, or we've got a hotline here, and let us know, and leave that to us to say, well, actually we think that you're okay, but you need to go and see your GP because of that symptom. Or if we think that you need assessment sooner, then we'll do that. Or if we think that you need it really soon, we may advise you to go to accident and emergency. So I think if you're getting problems, then let us know, and let us try and work out whether it's related to the CLL or not, and then go from there. So I think there's that kind of you telling us any symptoms that you've had or any problems. And then also if you've got any information that you want to know from us, so whether it's your blood tests or whether it's actually you need to know more information about the drugs that you may be approaching, requiring, needing. And then from the doctor side, we don't have a checklist like, they do pre-operation that we have to go through to ask you. So different doctors will do different things, and it could, and in different clinics we'll do different amounts. If it's a really busy clinic and we're running 3 hours behind time, it's going to be a shorter list than if we're at the beginning of clinic and fresh and there's not much of a queue. So, but broadly speaking, I'll be asking about symptoms that might suggest the disease is progressing. So if anyone's noticed any new lumps or bumps, if they've had any weight loss, any new symptoms, any night sweats, any symptoms of low blood count, so tiredness, fatigue, increase of infections, and those sides of things, to see whether there's any symptoms to suggest the disease is progressing. Then a lot of the conversation is about COVID as well at the moment. So it'll be partly talking about vaccinations, ensuring people or advising people that they should have the vaccinations, and where we are with the vaccinations and which vaccination they should be getting next. And then, a lot of the questions that we get at the moment that we talk through with the patient is about, is it safe for them to do X, Y, or Z, which are always hard questions. But I think sometimes it is worth, if you're worried about things, talking through those risks with the healthcare professional that you're seeing.
Great, and I think that's answered the question in terms of what should I be keeping an eye on in between appointments. You've given us a whole list of symptoms. It's keep an eye on that. Nick, you're pulling some faces. Come on.
I was going to say
tell me what you would do.
Of that. I was having a chat with a friend earlier actually about, remember the old days when we used to have a calendar on the kitchen wall, and you'd flip the picture and it was quite easy to write something down on that day. Human nature is you go to see your doc if you haven't prepared beforehand and you haven't collected that information in some shape or form. Doc says, how are you feeling? I'm all right, doc. At that moment in time, those appointments can often be at one moment in time. So I think what needs to be added to that as well is just some sort of a process where you can retain that information of when you felt unwell, when it was, how frequent it was. And yeah, I was going to say about asking questions. I guess I'm ordered that people have agendas in business meetings. If you can kind of order yourself in that way, that there's going to be the business side of the consult where you're going to be palpated, is the word they use, where you're going to have your physical, you're going to have some results, and then that bit about sharing a bit about you and then sharing what you've been experiencing. If you can do that, I think we probably do it the longer we've been patients automatically because we're used to the process. But the one thing that we're not good at is noting all those little things that might be going on in the time beforehand. And I've seriously thought myself, I mean, I don't need to at the moment, touch wood, but of actually going back to having a nice calendar on the wall. And you drop things down, momentous moments, because there aren't that many in COVID, are there? But sorry, that was what I would say. It's good to have a system as well where you're actually collecting that information so you can refer back to it.
Yeah, that's helpful. Helen, is there anything that you find particularly helpful for patients to share with you?
I think it's making sure the patient is prepared. I think, as they said, with a face-to-face, they've got that time to prepare, and there's a whole process of preparing before you go, getting there, and they know where they stand. I think with telephone conversations, sometimes they don't happen at the time you're expecting, and you may just be caught on the hop and someone's knocked at the door and it just throws things out of sync, and you sometimes don't feel in the right headspace really then to have a conversation over the phone. And as you said, that your questions change over time as well, depending on where you're at. And that's fine. Some people just want to know what the blood results are. You tell them they're fine. That's it. Conversation done. I'm happy. I'll go now. I don't want to know anymore. That's it. That's the main bit of information I want to take away. And I think you mentioned about knowing what symptoms are part of the CLL and what's not. So you're going to get coughs and colds and things like that that are going to be completely unrelated to your CLL, but there's always that niggling worry that is it changing, is things progressing? I suppose we're there to help guide you through that, and as Dima said, just ring and ask. Really, you can use us as we'll triage you as such really and go through that and see whether we think it is related, whether we need to see you any sooner or see you face to face. So always ask really, and don't write things off. I think sometimes it can be a passing comment at the end of a telephone conversation that might be the key bit of information that you might need to press on really, that maybe you thought nothing of. So try and mention as much as you can if you possibly can, that you feel comfortable to say.
Don't filter yourself.
Yeah.
And then just to add some detail on, because a lot of the patients might be on continuous therapy, so as well as those that are kind of approaching, perhaps looking for signs that they're approaching requiring therapy, for those on therapy, we'll also be asking questions about the potential side effects of the therapy. So, for example, those on BTK inhibitors, particularly now that a lot of patients are having virtual consults, it's asking, are they checking their blood pressure, palpitations, bleeding and bruising, and the side effects that we know can occur with these drugs.
Yeah,
that's a really good point, Dima, because I've got, I don't know how many patients they're in that circumstance, but, to have their own blood pressure monitor and be able to share that information. And I guess we're wary and we do understand those side effects, but is actually having those discussions every now and then at the appointments, because it's quite easy. I don't know if it's a matter of fact for the consultant, if you don't bring it up, just to move on, generally you're coping really well, everything's fine. But what is apparent that with these treatments over time, you need that information, because the longer you're on the treatment, things might start to emerge, for example. And you just raised a few points earlier about I mentioned it earlier about not thinking things are the new normal because you've never been there before. You don't know what you should be experiencing. And before I was treated the first time, I ended up having a heart attack. I ended up being stented because I'd been living with heart disease and the progressing symptoms of heart disease. I'd never got older before, and I'd never had CLL before. And I just thought this was part of progression. And I didn't talk with my healthcare consultants, the healthcare team, about some of these, so they weren't aware. And I think that's the important thing, is don't obsess about things. If you find yourself in a stable position, you're post-treatment of a fixed duration treatment, you can get on with life again. You've just got things in the back of your mind, you're stable the same. And same if you're on a therapy, a continuous therapy. But just make sure you do, if you can, note those down and don't put them to the back of your head. I don't know if it's a male thing more than women as well, that we're not as good at reporting those things, but I think it is important that we do. That's the only opportunity we have to do that, really.
I think that's a really good point, actually, Nick, because, you know, we can ask you questions about things related to your CLL that might occur when it's progressing, but we know that CLL can have rare complications and rare symptoms that not everyone will get. So we might not specifically ask that question. And similarly, you might be getting symptoms related to something completely unrelated, such as, you know, if you're getting chest pains, but just tell us. If you're getting problems, tell us. And if we think it's not related to the CLL, then at least you've told someone who'll be able to start the investigation process and refer you, or ask your GP to refer you to the appropriate specialist. So volunteer that information. Don't be proactive rather than reactive and wait to be asked.
Great. Dima, we've talked a lot about people sort of offering up their thoughts on how things are going and what they want to achieve. Approaching treatment, you know, you as a doctor, you've talked in your presentation at the beginning about how you want to know from the patient what they want to achieve as well. Someone's asked if there is ever a point where people come across to you as a doctor as asking too many challenging questions. Is that ever something that you think? I think I know what the answer is going to be.
I'm going to be honest here. I think the people that are annoyed by challenging questions are perhaps nervous that they don't want to appear knowledgeable. And as you get more senior, perhaps you're more comfortable with saying, I don't know. I like being challenged. I like being asked, because it means that the patient is engaged with and in wanting to understand their own disease and what the thought process is as to why we're going to give them one particular drug or one particular therapy over another. And there are going to be questions that I don't know, or that nobody knows, and I think it's all right. And, you know, I think in busy clinics, people can get frustrated, and this is just human factors, isn't it? And they might try and brush off your questions. But as Nick mentioned, one of the luxuries, if you can call it that, with CLL is that we do have the benefit of time, and we can tell that people are approaching requiring therapy on the most part. So it isn't something that has to be kind of discussed and decided and done and dusted in one consult. For me, often it's over 2 or 3 or even more consults, so that you can ask the questions in stages, if you like. So personally, I like the challenging questions, but I do know that people can get frustrated or hide their lack of knowledge by just brushing them off, or yes, just fobbing them off and saying something that's not relevant.
Yeah, I always say to people who come to me and say, my doctor isn't answering this question, I say, have you tried writing it down where they've got more time to think about it? Have you tried this? Have you tried that? You know, we're all human. I do try and help people with that, but it is a challenge, I'm sure, when you've got a busy clinic. Helen, how about you? Do you get a lot of challenging questions from your patients?
I think it's nice that they feel empowered that they can go and look that up and talk to you about it as well and ask you questions. I think it's good. I think sometimes, especially with COVID and things, my patients have told me before I found out some things, like with the 3rd primary dose and things like that. A patient told me first because they'd read it before we would even been told. So I think it's a positive thing, really, that, and they feel able to talk to you about it. I think it's a good thing. But don't expect it of everybody. It's not for everybody that they need to research everything. But it's
Yeah, absolutely. Knowledge is power, and you know, the hard thing is early on, you will be maybe the hardest thing is to learn and research the right information, and it takes a bit of time to find out that right information. But you know, the educated or the non-empowered patient has a better outcome. And I must apologise, and I will do it at some point in my history, to all of the healthcare professionals that I totally did their heads in with the amount of information that I used to overload them with. I was so thankful that I happened to be, by chance, paired up with one of the world leaders in research who harnessed that power and helped me through that rather difficult stage. And I think that's what you do, you know, listening to lots of others, is that you not only answer the questions, but you also help patients to reach those answers themselves. And sometimes it takes that process. And I think it's really important that to understand living with your condition, you need to do some work yourself. You know, you need that information, you need access to that. You can't have shared decision-making discussions unless you have that depth of knowledge. So from all of the clinicians I talk to answering that question, they feel empowered. But I like your candid honesty there, that as you get older and more experienced, that you can actually say, well, I actually don't know the answer to that one. But yeah, no, absolutely. Never stop learning. Knowledge is power. Just learn with time what's relevant to you in CLL. That's part of the challenge, because CLL is probably many, many diseases together, and yours is behaving in a specific way, and what's relevant to you is what's relevant to you. What's relevant to everybody else isn't relevant to everybody, to you. Yes,
I always find with this and other types of chronic leukemias, is comparing to others is very unhelpful. I always think that's not a helpful exercise. Thank you.
That's most definitely a good point, that don't think because someone else has suffered with that you're going to get exactly the same thing, because it is really different, and it muddies your water a little bit. Really, you need to concentrate on you, isn't it? Really, it's very individual.
Yeah.
The other thing with the consult is sometimes it's just as important that we're signposting to where you can get reliable information from, because we all learn and gather information in different ways. And for example, for me, I learn and retain much more information reading something than I do from a lecture, and I like having that combination. And it's the same with what you're getting from the clinic consult. You might not feel like that might be the starting point for you, but actually you need the written information as well to help you retain some of that. So don't feel that that's the only place to get information, but that they can help signpost you, as can Leukemia Care, to where you can get more other information in other ways.
Absolutely, that's sort of why we at Leukemia Care are trying to do videos and written things down and podcasts and all sorts, because appreciating that not everyone absorbs information in the same way. It's really, really important to remember that.
Or from the same source. I think one thing we find with time is that we all dip into different bits of information to form a picture that fits ourselves.
Definitely.
Make sure it's reputable. Make sure it's reputable.
Yes, absolutely. I wanted to address this question from someone whose dad has CLL, because I think we often talk about the patient in these things, but very rarely bring in the family and friends. So thank you for coming along and asking your question to that person. They mainly asked about what signs and symptoms we should look out for, which I think you covered earlier, Dima. But Helen, I wanted to ask you if generally you as a sort of CNS team are open to family and friends. Are they able to come to you and ask exactly the same questions that patients are?
Yeah, most definitely. I think with the patient's consent that we can talk to family and friends as well, just to make sure that we get all sorts of different family situations, just to make sure that we're aware. But I think sometimes you can learn more from family and friends than the patient sometimes, that they're seeing things that the patient isn't telling you. Maybe the patient doesn't want to see it themselves. We get it a lot when you get, especially face to face, that the patient will tell you one thing and then the person with them will be like, that's not what's happening at all, and you get a different story, really. So that can happen. But yeah, I think, and it helps the patient sometimes that someone else is with them and has an understanding and can listen to the consultations as well, which I think sometimes the telephone conversations take away from that, because they can't always, maybe don't have the power to listen in as well to those conversations. So but they're very much part of it as well, I think, with the patient's consent, most definitely.
Yeah, absolutely. Great, thank you. Oh, we've covered so much. I'm just going to catch up with where we are at very quickly.
Whilst you're doing that, I'll fill a bit that I think that COVID has had an impact on how much the supporters, whether that be children, parents, partners, have been able to be involved in these discussions. So say we are limited to just the patient coming to clinic consults unless there's extenuating circumstances, and you know, if someone's about to require therapy and we do need to have quite a complex conversation, is one of the, luckily at the moment, one of the extenuating circumstances where we would be allowed a partner in perhaps for that one consult. But the rest of them, you know, different services are doing different things, but we're trying as much as possible, if, you know, having them on a phone, so although they're not there present in the room with us, then they are on a phone and at least listening in on the conversation. But then just going back to the site of the consult, for us, for myself personally, and what we're doing here is, as patients are requiring therapy or a change of therapy, then if we had been seeing them or managing them virtually, then we will try and bring them into hospital, because to pick up on the non-verbal cues, to ensure that they understand what we're saying, because we know most people are nice people and they don't want to tell us when they don't understand what you're saying to them. But sometimes you can pick up when they look a bit confused, but you might not pick that up on a phone. So I think, yeah, we do try to bring patients in when we're going to have some of those more complex conversations.
Yeah, absolutely. Any other advantages or disadvantages from your perspective, Helen, about telephone consultations? And then I'll come to you, Nick, see what you think.
I think patients that are used to the whole process and just want to know the blood results, telephone conversations have been perfect for them, really. They haven't got to deal with getting to the hospital and parking, which is atrocious in Nottingham, probably in other places, so they can go and get their blood test done beforehand, and all they want is that bit of information, really. That works really, really well, I think, and a lot of patients have said, I don't really want to move back to face-to-face, I'm happy with a telephone conversation. If things change, then we can look at it later on, but that seems to be the way forward for quite a lot of patients. Some like the day out, some like the trip out because they aren't going anywhere else, so they'd like to come to the hospital because that's about the only chance they can get out at the moment. And I think they like to see you, and especially we do with, if it's treatment related or if it's a new diagnosis, we'll try and see them face to face, most definitely. Even things like drawing little diagrams for patients, just being that face to face to be able to show them processes and things makes a massive difference that you just cannot do over the telephone. It's just impossible. And I think if you get that understanding better at the beginning, then there'll be less telephone conversations backwards and forwards of trying to reiterate information, take the stress off the patient, that they've got a better understanding from the very beginning, really.
Yeah, we've talked a lot today about shared decision making and two-way communication and things, and it sounds as if if there is a more of a two-way conversation involved, then face-to-face is better. But please do correct me if you guys, you're nodding, so I'll take that as a good summary. Nick, how about from the patient perspective? Is it the same for you?
Maybe three things. Processing, time to process. You know, one thing I always remember, no matter where I was in my CLL journey, the second I stepped through the front door and I saw the long corridor and I had that walk, I was no longer on my time, I was on CLL's time, and then the wait, you know, and the whole process gave you time to sort of process where you're at and everything else. It goes back to that question you said about preparing for your appointment. And I think the other thing, it's about building relationships, that reaffirming friend, you know, your doctor becomes a friend in a way. I know we shouldn't say that, but it is, it's a friendship, it's a mutual relationship, and you can't do that over the phone. It's very clipped, it's very clinical, it's very two-dimensional, one-dimensional even, and okay, you know, it's a pain. We're missing it now. We're missing that physical contact and that physical medicine. There's something healing about having the confidence of your nurse or your doctor who is using their science and their healing power to heal you, and you're building a relationship together, and that you don't get that over the phone. And our data reflects that. You know, our surveys during COVID, you know, the majority of patients, even though they might be faring better through COVID, still want the choice. And if you looked at the initial survey at the beginning, I was quite surprised by the number of patients whose last consultation was actually an in-person one. So it looks as if practice got back to it very quickly. Obviously, we're now coming into another storm and things are going to change for a little while, and hopefully we can all get back there again, because we need the face-to-face consults.
Yeah, absolutely. Someone's just commented that it's not all about blood results. I think we have agreed with you throughout this. Apologies if we haven't, but I think we talked a bit about physical examinations earlier, and obviously that needs to be done in person. And if you are having trouble getting a face-to-face appointment, just come and talk to us in the advocacy team and we can help you sort that situation out. But apologies if you don't feel like we are representing you. We're doing our best to cover everyone's experiences in this webinar. I think we've sort of covered the vast majority of our questions throughout the conversation this afternoon. Maybe a couple more practical points to end on. We touched on visitation. Dima, you mentioned it earlier. I wondered whether you see there being restrictions for some time to come with COVID, and is it quite variable across the country on that front?
I've given up predicting what's going to happen with COVID, and I think all of us have. I think it's here, and I can't see things changing too quickly. I think that you kind of think about pre-COVID, that there were infections before COVID, and how it was acceptable to put everyone in such cramped waiting rooms before.
Yeah.
I kind of think, why would we ever have thought that was a sensible thing to do?
You never knew how much we were cringing. You never knew how much we were struggling with that. You know,
yes.
that's the truth. But we had to strike a balance, and we did.
Yes.
And we had to live with flu, we had to live with potential pneumonia. We knew we didn't respond. How do we strike a new balance?
And so I do think that one of these things is just dramatically cutting down footfall into the hospital, because COVID, other infections, we just have to reduce that risk of catching things, and so we have to draw the line. You know, different hospitals will have different policies as to who is allowed to come in, and I think that, you know, when you're having the more complex conversations, then it is useful having someone else there, whether it's on the end of the phone or in person. But it is very centre dependent and dependent on the time in the pandemic, and I'm sure it will change over time.
Nick, I knew I was going to be on mute at some point. Nick, I wanted to give you the final word on this. Any final tips for patients that we haven't already covered? I know you've covered a lot already, but I like to end on practical stuff. Anything we haven't mentioned already, practical wise, for getting through CLL generally day to day, but appointment to appointment.
I think practical is, maybe COVID's helped with understanding that our healthcare team, they're just people. They're people trying to help us. We're all just people trying to get through this together. Time. Nothing's going to happen. Well, it can. So that's the wrong way to say it. It shouldn't, but things don't tend to happen overnight. You've got time to deal with things. You've got time to learn. You've got time to prepare yourself. Prepare yourself if you can. If you've got burning questions, if you've got feelings of things aren't right, be confident, and, you know, talk to your clinical nurse specialist if you have, talk to your care team. And if you find that you've got barriers in that respect and you can still benefit, I think one thing to remember as well are us patients as a group. You know, we started a culture many years ago of advocating for each other, sharing how to do things, and then we pass it forward. And things like the Health Unlocked community, the different Facebook groups, the support groups at Leukaemia Care, there's a lot of value there also to help you grow and help you deal with that. Sometimes you just need to rant, and maybe the doctor's the wrong person to rant at. Yeah, and you kind of learn that. And just be confident that there's no such thing as a stupid question, and that the more questions you ask, the happier your care team are. And I'm rubbish at it preparing. I shoot from the hip. I'm not going to react about CLL until something's wrong. So hopefully nothing will go wrong. And that's the whole point of it. That's what I said earlier. In reality, the more boring a patient you are, the better your life is. So on the learning, if you've got burning issues, deal with them, talk to your healthcare team about them. If you need to learn something, learn what you need to know and try and put it on the shelf, and get on with life a little bit, because if you don't deal with it, you can't.
Great, thank you, Nick. And there's already some lovely comments coming in about how useful they've found this conversation, which is always nice to see at the end of a webinar. Right. Let me finish today's webinar with just going over a few short slides to remind you all of how to access other services we provide. Just wait for those to load on full screen. So this is our last webinar for this year, but we have already got a few more in the works. No solid dates to confirm yet, but we are looking to, whoopsie, the slides are moving on their own. Let's try and go backwards a bit. We are looking to do some updates from the American Society of Haematology conference in terms of treatment updates and things. So if you're interested in the latest in what's going on in CLL or other leukemia types, keep an eye out on our newsletters and things, and we will share those dates as soon as we have them. But also, as the list says, lots of other ways you can keep in touch with what we're up to here. We thought it would be useful to share this particular blog that we wrote probably about a year ago now, but I'd say that all the tips are still very relevant if you're having telephone consultations and they're the only option for you at the moment. Please do use that resource on the website. We have loads of booklets on CLL, starting treatment and the different types of treatment. So do check out the website where you can order them or you can download them, whatever your preference is.
We've got a terrific new one at the moment that's worth a read. I'm really impressed by it.
Yes, we've just published our joint one with Lymphoma Action, and it is very good. Thank you, Nick, for pointing that out. Here's just a list of our support services. We mentioned the advocacy support team throughout, so don't forget that we can help you if you've got any queries about your care. And here's how to get in touch with us. We've got our own special page on the website, or you can just call the helpline and say, I'd like to speak to so-and-so about this or that, and we'll always make sure you get to the right person. Just tell us what your question is. Here's the ways you can stay in touch with the latest from us on social media if you're into that kind of thing. And a reminder of our helpline and our generic support email address to get in touch. Thank you to our speakers today. You've been fantastic. It's been a really interesting conversation. You've all been very honest about your experiences, which is always really helpful for these webinars. And I hope you all have a lovely Christmas and a not too stressful Christmas for the two of you working in the NHS. And thank you again, and see you all again at another webinar. Bye, everyone.
Happy Christmas, everybody.
Thanks. Bye.
Thank you.
Bye-bye.
Bye.